I am Nacha Melosa and I will be presenting joint mobilization techniques of the lower extremity. So I have a 35-year-old patient who sustained multiple traumas to the right lower extremity 8 weeks ago after being sideswept by a car. The patient currently presents with pain and reduced range of motion of the hip, knee and ankle due to sustaining a fracture of the femoral neck, ACL and MCL tears at the knee, and severe lateral ankle sprain. I will begin with the hip. Since the patient has minimal pain of 3 out of 10 at the hip, but has 50% limitation of hip extension, abduction, and internal rotation, the focus of treatment will be to increase range of motion of the hip. For the hip joint, we have the concave acetabulum articulating with the convex femoral head. To increase hip extension, I am going to glide the femur in an anterior direction. The patient is in relaxed position and prone, using pillows if necessary, especially if the patient has back issues. I place a rolled up towel under the patient's thigh. With one hand, I am supporting the patient's lower leg, and then I have this hand on the proximal thigh, just below the buttock, and applying a force in an anterior direction. For increased range of motion, I am doing grade 3 mobilization, which is large amplitude into resistance or up to the point of limitation, and progress to grade 4, which is small amplitude at the end of the range. A treatment progression would be to glide and provide physiological extension. So I'm making sure that I am using my body and not my upper extremities. To increase hip abduction, I have my patient in supine with the hip to about 90 degrees and the lower leg placed on my shoulder. Explaining to my patient where my hands will be placed, I am going to glide the femur in an inferior direction, with my hands close to the joint line. To increase abduction, I am providing grade 3 large amplitude into resistance. And grade 4, small movements well into resistance. So I'm using my body and not my hands to provide the force by weight shifting. To increase hip internal rotation, I am going to use my mobilization belt and explain to my patient what the belt is for. A gapping motion is provided with the hip pre-positioned into internal rotation. Grade 3 large amplitude is provided with me doing my hip extension up to the point of limitation, and grade 4 small movements well into resistance. Through range physiological internal rotation can also be done together with accessory gapping motion. For the knee, since the patient also has minimal complaints of pain at the knee, but restrictions in range of motion, treatment will be focused on increasing range of motion. So for the tibiofemoral joint, we have the concave tibial plateaus articulating on the convex femoral condyles. To increase knee flexion, the patient is in supine with the knee in a resting position of 25 degrees of flexion. Posterior glide is provided to the tibia to increase flexion. Grade 3, large amplitude into resistance, and grade 4, small amplitude well into resistance or at the end of the range. To increase mobility of the patella, with the femur in a neutral position, I can cup the patella and glide the patella in an inferior direction. I can also use the thinner eminence of this hand to increase inferior glide of the patella. So grade 3, large amplitude into resistance, And grade 4, small amplitude at the end of the range. Using the thumbs of both hands or the heel of one hand, glide the patella in medial direction to increase patellar medial glider mobility. Grade 3, large amplitude into resistance. And grade 4, small amplitude well into resistance. For the ankle, the patient presents with considerable pain of 6 out of 10 and restrictions in ankle range of motion due to being immobilized in the boot for 6 weeks. To address the ankle pain, joint mobilizations will begin with grade 1 and progress to the next grades of mobilization based on the patient's response and joint assessment to increase ankle range of motion. For the upper ankle or the talocrural joint, we have the convex talus articulating with the concave tibia and fibula. To reduce pain and increase range of ankle dorsiflexion, posterior glide is applied by pushing against the talus. I am using my other hand to stabilize the leg. So grade 1 is small movement at the beginning of the range. Grade 2 is large amplitude free of resistance. Grade 3 is large amplitude into resistance. And grade 4, small amplitude well into resistance or at the end of the range. To reduce pain and increase ankle plantar flexion, I have my patient in prone with the foot over the edge of the table and the lower leg supported with a rolled up towel. An anterior glide is applied by pushing against the calcaneus. So grade 1 is small movement at the beginning of the range. Grade 2 is large amplitude free of resistance. Grade 3 is large amplitude into resistance. And grade 4 is small amplitude at the end of the range. At the subtalar or talocalcaneal joint, we have the convex calcaneus articulating with the concave talus. To reduce pain and increase eversion, medial glide is applied by pushing against the lateral side of the calcaneus and the other hand stabilizing the talus. Grade 1 is small movement at the beginning of the range. Grade 2, large amplitude free of resistance. Grade 3, large amplitude into resistance. And grade 4, small amplitude well into resistance. If the patient had limited range of ankle inversion, lateral glide is applied by pushing against the medial side of the calcaneus. Grade 1 is small movement at the beginning of the range. Grade 2 is large amplitude free of resistance. Grade 3 is large amplitude into resistance. And grade 4 is small amplitude at the end of the range. An alternate position for joint mobilization of the subtalar joint is to have the patient inside lying and moving the calcaneus in the medial or lateral direction.